KiaFatt. I'm from Jeffrey Chia School of Medicine and Health Sciences, Monash, UC Malaysia. My area of expertise is in statistics and epidemiology, and one of my area of research is on men's health. So today, my topic of presentation is on sexual dysfunction and quality of life. Sorry. Now, male sexual dysfunction is divided into two aspects: erectile dysfunction, or what we call ED, and the other one is premature ejaculation. ED, or erectile dysfunction, is the inability to have erections of the penis adequate for sexual intercourse. It is also called impotence. Premature ejaculation, on the other hand, is the inability to control or delay ejaculation, which result in dissatisfaction or distress. This presentation is divided into two parts. First, I'm going to present on erectile dysfunction and quality of life, and the other parts, the second part will be a premature ejaculation and quality of life. To begin with, I will present on the erectile dysfunction part. The overall global prevalence was found to be varies from 13.1 to 71.2% based on the reports on 5 continents such as North America, Europe, Oceania, Asia, and Africa. From the prevalence study, it was found that ED prevalence increases with age. And young men aged less than 40 years had higher prevalence of ED. And there was no apparent trend in ED severity among all age groups. It means that the ED severity is similar according to all age groups. Among the risk factors for ED are age, coronary artery or peripheral vascular disease, hypertension, obesity or sedentary lifestyle, hyperlipidemia, trauma or surgery to the pelvis or spine. In terms of work productivity, respondents with ED also showed high absenteeism, increment productivity impairment as compared to respondents without ED. In terms of impact on partners' quality of life, the female partners are reported to have significantly reduced in sexual desire, arousals, orgasm during sexual activity, satisfaction in sexual relationship, and less engagement in sexual activity after their partner developed ED. In another study done in Taiwan, they also found that the female partners experiencing problems with arousals, orgasm, sexual satisfaction, and sexual pain. And the females had a significantly higher prevalence of sexual difficulty in every female sexual function index domain than female partners of men without ED. For example, overall sexual difficulty, desire difficulty, arousal difficulty, orgasm difficulty, and pain difficulty. A study done in Israel also showed that the female partners of men with ED who visited sexual medicine clinic regularly, 65% of them had complained of more than one sexual issue, such as decreased sexual desire, arousal disorders, lack of orgasm, dyspareunia, and vaginismus. And the psychosexual effects and relative high levels of sexual desire in female partners continue to exacerbate the ED condition. In another study done on the female sexual dysfunction among young and middle-aged women in Hong Kong, reported that the female sexual functions are affected by premature ejaculation and erectile dysfunction, and they seek more medical help, as shown in this table. In another study done on Arabic females, the study found that the higher prevalence of female sexual dysfunction were majority depression and complaint of the male shortcomings such as erectile dysfunctions and premature ejaculation. Dissections with the partner's penile style, size, insufficient foreplay, and practice of masturbation. Due to the different education and cultural backgrounds of the Chinese and Arabic, prevalence of female sexual dysfunction in Chinese and Arabic women is underestimated compared to Western countries. Overall, the erectile dysfunctions has a psychological impact on the men's as well on the erection, emasculated sense of insecurity, worthlessness, perceived inability to satisfy partner, believing partner will leave him as a result. On the other hand, the female partner will feel guilty, rejected, frustrated, feeling unloved, unwanted, doubting own attractiveness, doubting man's fidelity, questioning the integrity of the relationship, withdrawal of intimacy, and sense of shame. The second part of my presentation is on the premature ejaculation and quality of life. PE refers to ejaculation happens sooner than the man or his partner would like during sex. It's also known as rapid ejaculation. Prevalence of PE varies from as low as 4% to as high as 65%, depending on the method used to define PE. For example, premature ejaculation diagnostic 2, diagnostic statistical manual 4, index of premature ejaculation, self-report, and others. The global study of sexual attitudes and behaviors, which is a large survey on prevalence of sexual dysfunction in 29 countries, indicated that rapid ejaculation is the main complaint. It was found that the prevalence of rapid ejaculation were more than 20% in Europe, South America, and Asia. This table shows the summary of 4 classifications of premature ejaculation, namely lifelong, which is the primary, acquired, which is secondary, variable, and subjective. IL is denoted as the intravaginal ejaculatory latency time, which is defined as a time taken by a man to ejaculate after vaginal penetration. For lifelong, the LL criteria is less than 1 minute, whereas for acquired is less than 3 minutes. Variable is between short to normal. Subjective is normal or prolonged. In terms of symptoms, for lifelong is ejaculation occurs too early in nearly every sexual encounter, whereas for acquired is a new onset of premature ejaculation, but the patient has experienced normal ejaculation in the past. For variable, the PE is inconsistent and occurs irregularly and not result of a psychopathology, whereas for subjective, it's a self-perception of rapid ejaculation despite normal ejaculation time. In terms of onset, for lifelong is early, usually from a first sexual encounter, whereas for acquired can occur anytime in the man's life. Similarly for variable and subjective. In terms of PE criteria, PE is defined by 3 aspects. One is the ejaculation that always or nearly always occurs before or within approximately 1 minute of vaginal penetration, which is referring to a lifelong premature ejaculation, or a clinically significant and bothersome decrease in latency time, often no longer than approximately 3 minutes, which is referring to the acquired premature ejaculation. The second criteria is the inability to delay ejaculation, all or nearly all vaginal penetrations. And thirdly, negative personal consequences such as distress, bother, frustration, and or avoidance of sexual intimacy. Among the risk factors for PE are folate deficiency, neurobiological and genetic factors or genetic predisposition. Although there's a link in terms of a genetic predisposition, but there was no clear evidence for first-degree relative of men with lifelong PE is a risk factor for PE. Next is the metabolic syndrome of diabetes, where the microvascular complications such as diabetic neuropathy may contribute to PE. Neurological disorders such as multiple sclerosis, cerebral vascular disease, traumatic brain injury can also be a risk factor for PE. Recreational drugs and alcohol, such as amphetamines and cocaine, are found to be associated with PE, while a few studies have shown association between alcohol and PE. Among others, risk factors for PE are chronic prostatitis, chronic pelvic pain syndrome, hypothyroidism. Emotional problems, depression, stress, anxiety also play a part. For example, depression from medical disorder, complications, and treatments contribute to performance anxiety. History of traumatic sexual experiences or conditioning, for example, frequent masturbating, improper masturbation, and learning how to ejaculate quickly to avoid being caught masturbating or not using any form of lubricant when masturbating and when having sexual intercourse with his partner. The moisture environment in the vagina will lead to fast ejaculation. Erectile dysfunction is also another risk factor for PE, where men who are anxious and worried of maintaining an erection during coitus may quickly rush to ejaculate. ED and PE are reciprocal. When a man attempts to achieve an erection via excitation, it may lead to PE. Likewise, when a man tries to control his ejaculation, it will reduce the excitation, which can lead to ED. Men who have a low frequencies of sexual activity tend to get more excited and aroused, which leads to performance anxiety and unable to control their ejaculation. In terms of treatment for PE, if the PE is due to medical condition, the treatment has to be focused on improving the underlying medical conditions such as angina or erectile dysfunction. Men suffering from PE should consult with psychiatrists or sex therapists if the underlying factors are found to be psychogenic, and seek help from a urologist or primary care physician if it's due to physical factors. The treatment is divided into non-pharmacological and pharmacological therapy. Among the non-pharmacological therapy are behavioral therapy, stop-start strategy, or it is called Master and Johnson technique, reducing the performance pressure on the male's partner, attempting second-time sexual intercourse, and psychotherapy, which can be a psychosexual therapy and relationship counseling. Among the pharmacology therapy are SSRIs, tricyclic antidepressants, phosphodiesterase type 5 inhibitors, desensitizing agents or local anesthetic agents such as SS cream, prilocaine, lidocaine cream, and alpha blockers, which was used to treat patients with lower urinary tract symptoms. Men with acquired PE were more likely to seek treatment when compared to men with lifelong PE. It is possible that men with lifelong PE comes to terms with their problem and not to seek treatment. Among the issues with PE are patients are reluctant to raise the subject of ejaculatory dysfunction with their physician because they are embarrassed and uncertain if there are effective treatments available to solve their problems. Clinicians fail to ask patients about their sexual matters due to insufficient time or uncomfortable asking about their sexual lives. Clinicians are more concerned with their health conditions that were associated with mortality and morbidity risk. Lack of recognition of PE also causes patients and partners significant distress. Lack of awareness of available treatment options. Some men do not care about their ejaculatory dysfunction. Some men are selfish and unconcerned with how long they last, and they deny or do not accept or recognize PE as a problem until their partner complains of dissatisfaction. Among the impact of PE on quality of life are half the men with PE reported relationship issues such as not able to satisfy their current partner or the reluctance of single men to establish new relationships. Half of the female patients with sexual problems such as not enjoying sex or anorgasmia had partners with PE. PE subjects tend to exhibit interpersonal difficulty compared to non-PE subjects. Men with PE reported lower levels of sexual functioning and less confidence in their overall relationship and tend to avoid discussing sexual issues or problems with their partner even though they understand fulfilling their partner's needs is important. In a study done in Turkey, it was found that men with acquired PE and lifelong PE, the mental and physical quality of life scores were lower compared to the control group. In a study done in Egypt, where 7,500 couples attending hospital seeking for medical consultation for a disease not related to PE, they found that the men with premature ejaculation have lower quality of life, where men recorded frustration, depressed, less like a man, less confident, anxious, angry, worried, embarrassed, guilty, rejecting partner, and feeling like lost something in sexual life. In terms of relationship between the quality of life and age in patients with premature ejaculation, quality of life were recorded poorly among the age group of 20s, 30s, and 40s as compared to over 50s age group. In terms of effect on the female sexual function, the female partner reported poor orgasm or poor satisfaction compared to other groups. A similar trend can be also seen in a study done in China, where the female sexual function scores and the subdomain scores were recorded lower compared to men's without PE, as shown here. And the female sexual function is associated with PE, and men's negative attitude towards the PE problem, introversion character, and depression of the man, as shown here. In a study done among the Korean men with premature ejaculation, it was found that the partners experiencing poor satisfaction, poor orgasm, and poor quality of life among the three methods of PE measurement. PEDT stands for premature ejaculation diagnostic tool. This one is referring to self-reporting and stopwatch, a timer to measure the PE. Among the methods used by the men in order to prolong their ejaculation time are behavioral therapy such as squeezing or interrupted stimulation, alcohol beverages, and focus attention on other than sex, as illustrated here. So in conclusion, ED and PE is a serious male sexual dysfunction. ED and PE affects all age group. ED and PE do matter to men as it causes men to be unhappy, depressed, and frustrated. ED and PE not only affects men, but also to their partners as well. Many men suffering from these conditions in silence, and many cases are still unreported. Men should seek counseling and treatment as there are medical treatment available to overcome their problems. At the same time, the female partner needs to understand and help her partner by providing the necessary moral support. That's all for my presentation. Thank you.